So it's a pleasure to be here and talk to you about what I think is an underappreciated disorder, particularly in the African American and Black communities, and one that's been overlooked by cardiologists, internists, and patients for years, and now is imminently treatable. So maybe you can just forward to the next slide. I want to be clear, I do have some research support from companies that have made compounds that treat patients with this condition, and probably most importantly, we've received a very large grant from the National Institutes of Health, particularly the Heart, Lung, and Blood Institute, to increase awareness about this particular condition. So if you can go to the next slide. So this is what I'm going to do quickly. I'm going to tell you who I am. I'm going to try to describe what transthyretin amyloidosis is, why it should be important to blacks, and how we are attempting to meet the unmet need. So next slide, we can just keep going. Click ahead. So I'm actually a New Yorker, born and bred, just so you know. I'm the youngest of 4 children. I actually am told by my brothers and sisters that I was a little bit of a mistake because my mother had me when she was 42 years of age, which back in the 60s was a little bit unusual. And if you can click forward, I became interested in geriatric cardiology in older adults because, believe it or not, on the right, there is my dad. He's 97. Lives on the Upper West Side with my daughter, and his brother is next to him who aged a little better. He's 102 and he lives in California. So, people did not live to be this ripe old age in the past, and I think we all have a inherent need to try to provide outstanding care to those individuals. I grew up on the Isle of Manhattan, so I've been making my way north, I always say. Stuyvesant High School at 14th Street. You can click next, but I did my medical training at a place you all recognize, which is City College and the Sophie Davis School of Biomedical Education. Made it to Mount Sinai for medical school, headed up to, that was a little bit moving downtown initially, been at Presbyterian, and my research laboratory is actually at the Allen Hospital at 220th Street and Broadway. So that's a little bit about who I am, and you can click forward. So what is this condition, if you can go forward on the next slide? So amyloid is a term we use to describe a protein that gets deposited around the cells in an organ. It could be in your kidney, it could be in your liver, it could be in your heart, it could be in your brain. And that protein disrupts the structure and the function of the organ. Most people are familiar with the term amyloid as it relates to a condition in the brain called Alzheimer's disease, right? So that's amyloid in the brain. We're talking about amyloid of the heart, and we like to, I don't say describe it this way, but maybe we're talking about an Alzheimer's or aging of the heart muscle. You can stay there. No, go back up. So there are lots of proteins that can get misfolded in the body. Believe it or not, everything in your body is made of proteins. And because us cardiologists are actually not that bright, there really are only 2 proteins that get stuck inside the heart. And the one that we're focused on today is one that's called transthyretin. It's a protein made by the liver, and its job in our bodies is to carry around our thyroid hormone and something called retinol, which is vitamin A. So it's got its name, transthyretin, because it transports thyroid hormone and retinol. And this particular protein can get stuck in the heart, and there are 2 forms of it. One that occurs with normal aging, and another that is actually genetic. And the genetic form of the disease clearly disproportionately afflicts people of African American descent. So we can go on. So this is a normal heart shown here on the left of structure, and as you can see, I'm just going to point and scream out loud. This is the heart muscle, it's not very thickened. And with amyloid, what happens is the protein deposits in the heart, and the walls of the heart go from 10 or 11 millimeters to 15 or 20 or 25 millimeters. The heart becomes very leathery, having trouble expanding or filling. You can go on to the next slide. So this disease, we know a lot about it now. The protein, as I mentioned, is made in your liver. It's made in my liver. Everyone makes this protein. We have a small little piece of DNA that tells us to make it. And the protein exists as what I call a 4-leaf clover. So you can see here, 1, 2, 3, 4. The protein fits together with each leaf of the protein being a single protein, and it links together like a 4-leaf clover. And in between the leaves of the protein is where your vitamin A and mine and your thyroid hormone and mine sit and gets transported around the body. As we get older, or if, God forbid, we were born with a mutation in this protein, the protein misfolds, and it doesn't stay together in its 4-leaf-like clover structure, but rather it falls apart. And those pieces can line up and form amyloid fibrils, which are these very stiff fibrils that interfere with the function of the organ. And this particular protein likes the heart, or in some people it gets stuck in the nerves, causing a neuropathy, like we were talking about with diabetes. So that's the biology of how this develops. You can go on. So this is not pie in the sky about treatments. We now have therapies to treat this particular problem. So one therapy that we have are drugs that are given by either intravenous or by a shot underneath the skin like insulin that, believe it or not, can go to your liver and tell your liver to stop making this one protein. It's what we call in the world of medicine gene silencing. This is not pie in the sky. These drugs are available. They're administered to patients, and they unequivocally slow down this particular disease or ameliorate it. A second strategy is shown in the blue, in which you can see in between the protein shown in yellow, there's a little red little blob. Those are a drug that fits in between the leaves of the protein. These are drugs that are available orally, so a little bit easier to take, and they stabilize the protein. If you prevent the protein from falling apart, then you can prevent the pieces from getting stuck inside your heart. So those are two strategies that are readily available to address this condition. The strategy shown all the way to the right is what I call the American strategy, and that is you wait for everything to get really, really bad, and you're really, really sick, and then you hope that something will work, and that's a way where we essentially try to degrade the amyloid from the heart. And that's a theory, but that hasn't worked very well. So we should all try to focus upstream on identifying this problem earlier and doing a little bit more prevention. Keep going. So why am I here talking to you about this particular condition? If you go on the next slide, this is the prevalence of genetic diseases that people might have heard about. So we're talking today about transthyretin amyloid. And I tell you, if you go to a newborn nursery today at Columbia Presbyterian, and you found 25 newborn babies who are black, and you sequence their gene and look for a mutation, 1 in 25 to 1 in 30 will have an abnormality in the gene that causes this problem. So sickle cell anemia occurs, just so you know, not to pick on it, but 1 in 5 or 600. And the other diseases are shown there. They're much less common. I didn't say they're less important, they're just much less common. And I, as a specialist in this particular arena, I'm still struggling to figure out why we don't get as much attention. One reason, to be honest, is that even if you have the gene, doesn't mean you're going to develop the disease. And even if you have the gene, the disease usually develops much later in life. And so in reality, I understand why we focus on certain conditions that may be not as common genetically, but impact on people's lives earlier and younger. But this is not, in my opinion, a rare condition. 1 in 25. So 3 to 4% of individuals carry a gene causing this problem. Go on to the next slide. These are data from a large registry in the United States in which we found 390 cases. And you can see in red, shown there, is the mutation that typically affects people of African American descent. It's called the VAL122 ILE mutation. What does that mean? It means that this protein actually has 127 positions to it, and at position number 122 of the 127, there's a switch in the genetic code where an amino acid called isoleucine, ILE, replaces valine. What does that mean? It means what I said. It causes the protein to misfold, and the protein then falls apart, and it gets stuck in your heart or your nerves, causing a lot of symptoms. You can go to the next slide. So this is a map I think people will recognize, but we've learned from studies that we and others have done, if you go to these respective countries, particularly if you see, I wrote here Ivory Coast, and in parentheses it says 44. So we went to the Ivory Coast and we genotyped 44 people. And we found that 3.6%, 0.036 is 3.6% of the people that we genotyped had that particular condition, this mutation. And you can see in Sierra Leone it was 3.4%, and Guinea is 3.8%. So along the west coast of Africa is where this mutation was founded or began, and it's not very common. You can look in other places, like in South Africa, it's only 1.1%. This is informative because we know that individuals from the west coast of Africa migrated and came to the United States, unfortunately, often not of their own free will. You can go to the next slide. So if 3 to 4% of people living in the United States who are African American have this condition, these are my math. We have 318,000 people living in the United States, of which 38,900 are self-identified as black. So there are 1.3 million people carrying this mutation in the United States. Doesn't sound too rare to me. And it depends upon how many will survive to be the age of 60 or 65 when this disease shows up, and it depends upon how penetrant the condition is, but we estimate that there's about 150,000 individuals in the United States with this condition. You can click on the next slide. This is a condition that if you have this gene, anyone in your family, your brother, your sister, your mother, your father, your children have a 50-50 chance of inheriting the condition. It's what we call autosomal dominant. So when we find one person in our clinical world, we really are encouraging people to get other family members, particularly family members who were a similar age, tested, because we don't want to continue to miss this particular disease. You can go on and say, so I know that if you have this gene, and I were to look at the pathology on your heart under a microscope, it's there, the amyloid is always there. What I don't know, if you click, is if you have this disease, how much does it really affect the quality and quantity of your life? We believe that this gene is pretty penetrant. That means that at least 20%, but maybe more, of the people who carry the gene will develop disease. You can click forward. So this is a study done in London in which they began, I think London has, no offense, universal health care, a little bit better than the United States, in my opinion, where I personally think health care, I've always believed, is a right, not a privilege. But in London, they screened individuals. They screened individuals in the hospital who were Afro-Caribbean who had heart failure, and they found out that 10% of the individuals were carrying this particular disorder. This was the fourth leading cause of heart failure. Okay, number one was high blood pressure. Number two was ischemic heart disease, which Dr. Fergus has talked about. And number three was valvular disease. But this was number four on the list. Most cardiologists believe this is number 40 on the list. So unless we inform you that it's really important, I think you're going to have a hard time, especially when the doctors don't even know about it. You can go on. So this is an article that we published just last year in the New England Journal of Medicine, in which we show that one of those pills, this drug called tafamidis, which to be frank is not yet available in the pharmacy, but we will believe it will be available because it's being reviewed by the FDA this summer, when given to people with this condition, reduced the chance of dying by 33% and reduced the chance of being in the hospital by 32%. So this is not only not rare, it's not only easy to identify, but it's also able to be treated. But these drugs, as you'll see in the next slide, work better when given earlier. So in this study that I led, we had 441 people in the study, and we enrolled people who had heart failure, but they had various severities of heart failure. So NYHA class 1 is the first bar. That's when you have something wrong with your heart, but you generally feel pretty good and you can do everything you want. And of the 441 people in the trial, we identified only 37 who had this disease early, less than 10%. But if we gave this drug to those people who had the disease early, we reduced the chance of dying by 64%. However, if we wait till you're really short of breath, all the way at the end there, we still reduce the chance of dying, but the effect is much lower. And so it behooves us to really get out there and try to identify people now that we have an effective treatment earlier with this particular condition. You can go on to the next slide. So what are we going to try to do to fix this unmet need? We've been working on this for a long time, and I'll summarize quickly. You can go to the next slide. So the old way we had to diagnose this condition was to do a heart biopsy. Who wants to sign up to have their heart biopsy this afternoon? I didn't see anybody, right? So no one wants to have it, even though it's actually a pretty safe and easy to do procedure, but it's only available at like Mount Sinai Medical Center or Columbia. It's not available in your doctor's office. You can click, but this is a scanning test, a heart scan that we invented and others did that takes 6 minutes to do, could be done almost in any doctor's office. And I don't think you need to be a cardiologist to see at the bottom that the heart is glowing in the chest of someone with this condition where it's not in the top. So this scan has replaced the need for a biopsy. You can go on to the next slide. And so what I've tried to summarize this morning to you is the following. We've gone in the past from a condition that was a zebra, that was rare, that no one thought anybody had, to now one in which, as you get older, it's more common, and if you're African American, you're at risk for. So the prevalence is increasing, the awareness is increasing, and it's something that we need to address. And we've gone from a circumstance where we needed to have a heart biopsy to diagnose this to a circumstance in which we can scan people quickly in about 6 or 8 minutes under a camera and know if they have this condition or not. And we've gone from a circumstance where it's not only not rare and we can diagnose it easily, but now we can actually treat it. And so you can go on to the next slide. We have been asking the NIH to pay attention to this, and they have graciously done that. So your government has funded a study to be conducted in New York, predominantly in Harlem and in Boston, and it's called the SCAN-NP study. It stands for Screening for Cardiac Amyloidosis Using Nuclear Imaging in Only Minority Populations. Why do we focus on them? It's obvious. They carry the gene that causes this particular problem. We want to identify it earlier. So you can click. Our overall goal of the study is shown here. I am sick and tired as a doctor of seeing patients who come to my office too late, who are sick and have an advanced form of this disease, when I know that if I screened them and found it earlier, and I found it in their family members, I could do something to help them. But people show up too late with this particular condition, and we need to change our approach from one that's reactive to one that's proactive in a large way. So you can go on, the last slide. So this is a prospective cohort study in which we're inviting 800 people who are either self-identified as Black or self-identified as being from the Caribbean and Hispanic. Those are the only two people. Whites are not allowed in this study, okay? They all have to have heart failure, so we have to confer with their records and see where, and all of these patients have to be over the age of 60. Why? Because this disease, even if you have the gene when you're 20, I don't want to panic anyone, you don't get any symptoms at 20. It only shows up as you get older. And everyone in the study comes free of charge. We have transportation to pay for, an Uber to pick you up, bring you to our research facility where you spend a half a day with our staff, and we ask you a lot of questions, we examine you, we record your medicines, we give you an EKG, an ultrasound of your heart, and the scanning test. And we do your genetic testing to try to identify this. If we find out that you have this, we're very interested in, obviously, outside of the study, seeing the rest of your family members. Because as I told you, if you have this, there's a 50-50 chance that your brother or your sister or your cousin or your mother has this particular problem. And so what we hope to do is identify people earlier and give them access to what are effective and emerging treatments before the disease progresses. I'm happy to answer any questions. Thanks for your time.